Well, hello, I'm Dr. Michael Mirander, and today we want to just spend a medical minute talking about hepatitis C, which is the most common blood-borne infection in the United States. Said to have an incidence of about 4 million people in the United States infected with hepatitis C, 100 million worldwide, and a rate of about 35,000 new cases being found each year. Hepatitis C is a common cause of hepatocellular carcinoma. Some 80 to 90% of people infected with hepatitis C will go on to have chronic active hepatitis, and some 2 to 20% of these will go on to have cirrhosis of the liver. Hepatitis C is said to be caused by one of 6 different genotypes, with genotype 1 accounting for some 70% of hepatitis C infections. Genotype 1 causes infection that a lot of times are more difficult to respond to therapy. The genotype is not significant as far as development of chronic liver disease is concerned, only simply in its response to therapy. People with concomitant hepatitis B and HIV disease are seen in many people with hepatitis C, which is primarily contracted by blood-borne infections. A lot of these people get hepatitis C from blood transfusions. And certainly before 1991, when they weren't really screening for hepatitis C, a lot of people got hepatitis C from blood transfusions. Subsequent to that, the blood is screened for hepatitis C, and it doesn't really occur in that way. Adjunctively, people contact hepatitis C from needle-sharing behavior and even by blood-borne sexual contamination. Hepatitis C is generally not a very fulminant disease. Hepatitis C RNA is detectable some 3 weeks within onset of the condition. And certainly by symptoms occur, hepatitis C RNA is detectable. Hepatitis C antibodies is detectable in some 50 to 70% of cases when symptoms occur. But sometimes it is some 3 months down the line that hepatitis C antibodies become detectable even after the original infection has set in. Many tests are available to look at hepatitis C infections. Enzyme immunoassays are frequently used as a screening test for hepatitis C. But you also have recombinant immunoassays, and you also have quantitative and qualitative hepatitis C virus RNA, as well as you have liver biopsy. As we said, generally the immunoassays are used for screening to see if you're susceptible or if you've had the infection. And if you get this as positive, then your quantitative and your qualitative hepatitis C viral RNA studies are done to kind of stage you as to how severely infected you might be. Quantitative hepatitis C virus RNA assays may be useful in predicting outcome of therapy, which is more likely to be favorable in patients with a low viral load. Liver biopsy. Although biopsy rarely detects other unsuspected liver disease The procedure provides valuable information on which to base treatment decisions. Patients with normal alanine aminotransferase levels and little or no fibrosis on biopsy have a favorable prognosis and may opt to defer treatment. Because of the shorter duration of treatment and more favorable outcome in patients with genotype 2 or genotype 3 infection, pre-treatment biopsy may not always be necessary in such persons. Screening for hepatocellular carcinoma is something that you need to do in a patient with hepatitis C viral infection. It's said to be an incidence of increasing potentials for hepatocellular carcinoma in these patients of 0.0 to 3% per annum. This is usually done by measuring alpha-fetoproteins and or liver ultrasounds on an annual basis. Screening also for concomitant HIV infection is done in most of these patients. And as we said, hepatitis B does have a high concordant infection with hepatitis C virus infection. One should be on the lookout for other diseases as stimulated by hepatitis C viral infection, as for example renal diseases, which is thought to occur as a result of abnormal proteins that are generated from the hepatitis C infections to cause a reaction, almost an immunoblastic reaction to the renal tissues. Now we're going to look at how treatment is oftentimes managed based on the results of your biopsies and your RNA levels and clinical position of the patient in terms of how ill they are or what subtypes of patients they are. Treatment consists generally of the use of interferon and ribavirin, because they have found that used synergistically you get a much more effective response. Pegylated interferon is thought to be a little bit more therapeutic than non-pegylated interferon. You want to treat and to get a sustained viral response. That means after a course of therapy for 24 weeks to have a viral hepatitis C viral RNA at an undetectable level. That is mean a baseline of 50 international units per mil. Generally speaking, within 2 weeks, one can have an idea of whether there will be a sustained viral response, in that one can appreciate a decrease in the viral RNA load within 3 weeks. If this is not appreciated, one can almost be thinking of terminating the course of therapy. Generally speaking, you want to treat anyone who is tending towards cirrhosis and who on the liver biopsy has evidence of fibrosis, especially to some significant degree, and also especially those with genotype 1. There are certain subsets of people who don't readily get treated for hepatitis C viral infections. Those include people who are IV drug abusers continually, people who are continuing to abuse alcohol, people who have concomitant medical conditions such as anemia, thrombocytopenia, leukopenia, patients with psychosis and or depression. A lot of times they don't readily gravitate to treating them with interferon and ribavirin. This is because a lot of these people will develop, as a side effect of the medication, psychosis, depression, and suicidal ideation. And it's become very complex to understand whether this is a progression of prior psychotic conditions or as a new finding. Also, patients with severe heart disease or end-stage renal disease oftentimes are not offered therapy for hepatitis C viral infections. It's always of prevention. It always is easier to prevent a disease than to treat or attempt to cure a disease. One should strongly encourage against IV drug abuse or multiplicity of partners and concomitant alcohol abuse. A lot of times you want to immunize patients against hepatitis B and hepatitis A, especially if they are even being treated for hepatitis C infection that causes, of course, the tendency to cirrhosis, hepatocellular carcinoma, fibrosis of the liver. Hepatitis C infection. Another medical minute. Trusting that this will have lent some spin on this condition and help you to appreciate its morbidity and mortality, its treatment, and some of the sequelae. Once again, I'm Dr. Michael Mirander. See you some other time in a medical minute.